Reproductive Health and HIV Institute are holding a virtual media briefing to announce a breakthrough in HIV prevention. They say initial results from clinical trials show that an injection every 8 weeks is more effective to prevent HIV among women in sub-Saharan Africa than taking a daily pill. Let's take you there in our live.
That people listening in are aware the profile of the various people who are speaking, and photographs of those people will be available both on the university's website as well as on the Wits Reproductive Health Institute's website. Then great pleasure to introduce Dr. Sinead Delaney-Moretwa, who, as I indicated, is the head of research at the Wits Reproductive Health Institute. Sinead.
Thanks very much, Professor Vella, and good morning to you all. I'm delighted to be able to share this important information regarding the HPTN 084 study. I'll first start by reviewing the study design of HPTN 084. The HIV Prevention Trials Network, or HPTN 084, was a phase 3 multi-center randomized double-blind controlled trial that was designed to evaluate the efficacy and safety of long-acting injectable cabotegravir to prevent sexual acquisition of HIV in women at risk for HIV infection. The study compared the effectiveness of cabotegravir to daily oral Truvada, and as you all know, Truvada has been shown to be highly effective for HIV prevention when taken as prescribed in a variety of populations and contexts. In HPTN 084, study participants were randomized in a 1-to-1 ratio to one of two study arms. One arm received active cabotegravir and a Truvada placebo, and the other arm received active Truvada and placebos for cabotegravir. Cabotegravir was then administered daily by mouth for 5 weeks and then via intramuscular injection at 8 weekly intervals after an initial 4-week interval load. Participants in both arms were offered open-label daily oral Truvada for 48 weeks after their final injection to cover the pharmacokinetic tail. I'll now review the study population that was enrolled. A total of 3,224 HIV uninfected participants were enrolled between November 2017 and November 2020 at 20 sites in 7 countries in sub-Saharan Africa, including in Botswana, Eswatini, Kenya, Malawi, South Africa, Uganda, and Zimbabwe. A total of 3,127 participants were included in the analysis at the time of the Data Safety and Monitoring Board review. The mean age of study participants was 26 years, and 57% of participants were 25 years or younger. 82% of the women enrolled were not living with their sexual partner. 55% reported 2 or more sexual partners in the past month, and 1/3 had a primary partner who was living with HIV or of unknown HIV status. Recognizing the challenges of COVID-19, the HPTN 084 study team developed plans to respond to the impact of the pandemic on study conduct. These plans included significant measures to protect study participants and staff during the peak of the pandemic. The team also proactively established metrics of disruption and used these to assess whether there would need to be administrative censoring of data during periods of disruption. And I'm very pleased to tell you that we did not meet any of the metrics for disruption. As of November 2020, participant visit completion at months 6, 12, 18, and 24 was 94%, 91%, 89%, and 91% of expected. I'll now tell you more about the NIH Multinational Data Safety and Monitoring Board review. I'm pleased to tell you that the blinded study reached its objective, and the DSMB recommended stopping of the current blinded portion of the study after its review on November the 5th. The DSMB considered the analysis of the preliminary findings of 38 incident cases of HIV infection. These 38 infections are included in the intent to treat analysis and are all infections deemed to have occurred after enrollment and are included in the analysis regardless of whether participants continue to take their assigned study drug. The overall incidence amongst all participants was low at 1%, suggesting that both cabotegravir and Truvada are highly effective for HIV prevention in this population. The 34 incident infections that were detected in participants assigned to Truvada is equivalent to an incidence of 1.79%, and 4 infections detected in participants assigned to cabotegravir is equivalent to an incidence of 0.21%. That is, we observed roughly 9 times the number of incident HIV infections in the Truvada arm compared to the cabotegravir arm, and the hazard ratio of cabotegravir versus Truvada was 0.11. The interpretation of this finding is that cabotegravir is 89% more effective than Truvada in preventing HIV infection in women, and the threshold for early stopping of the trial was met. Based on these findings, the Independent Data Safety and Monitoring Board recommended that the blinded portion of the study be stopped early and the results released to the scientific and broader community. In addition, in a random sample of approximately 362 participants receiving Truvada, plasma tenofovir concentrations were measured. 64% of those samples contained detectable concentrations of tenofovir, and 48% of specimens had concentrations of tenofovir consistent with daily use. This suggests that the study population was more adherent to daily oral Truvada than had originally been anticipated, and this likely conferred an even higher level of protection against HIV for Truvada recipients than had been assumed in the original trial design. To confirm, additional testing is currently underway to assess concentrations of tenofovir in plasma and dried blood spots for all those who acquired HIV infection after being assigned to Truvada. In addition, concentrations of cabotegravir in plasma for a subset of participants, as well as all those who acquired HIV infection, are being evaluated. Additional analyses are being performed to time the HIV infections in the participants who received cabotegravir relative to their last known clinic-provided injection, and resistance testing for incident HIV infections is in progress. Importantly, from a safety perspective, both cabotegravir and Truvada were safe and well tolerated in this trial. Most adverse events were mild or moderate and balanced by arm. We observed slightly more gastrointestinal symptoms in the Truvada arm, and in the cabotegravir arm, injection site reactions were more commonly observed, with 32% of women reporting injection site reactions in the cabotegravir arm compared to 9% in the Truvada arm. Importantly, these injection site reactions were mild to moderate pain or tenderness and mostly experienced at the first injection. And very importantly for us, none of the participants in the either arm discontinued injections due to injection-related side effects. I'm now going to let you know about the immediate next steps for this study. We have communicated with the research ethics committees and national drug regulatory authorities overseeing this study, as well as the site investigators, and study participants are being notified about the results as soon as possible. Participants will be able to learn about the medication that they were receiving, and a protocol amendment will be submitted for regulatory review to allow participants to continue taking their assigned medication or to switch to injectable cabotegravir if they choose. Participants on Truvada will be offered open-label injectable cabotegravir as soon as the medication can be made available. All participants currently on the study will be asked to continue on study, and if they choose not to remain in the study, they will be referred for the best local available HIV prevention services. We look forward to presenting these results in a peer-reviewed setting at upcoming conferences and in manuscript form as we continue to finalize the primary analysis and begin to work on important secondary analyses. I now just want to give you a brief update on other studies involving cabotegravir that are taking place. Earlier this year, a sibling study in cisgender men and transgender women called HPTN 083 showed a similar result, that a PrEP regimen containing long-acting cabotegravir injected once every 8 weeks was superior to daily oral Truvada amongst that trial population. And in addition, there are open-label adolescent bridging studies that are poised to provide critical safety and acceptability data in adolescents and young populations to support regulatory approvals for youth. Sub-studies in HPTN 084 include a contraceptive study, a qualitative study, and a sub-study of women who became pregnant during the trial, and they'll continue as planned. In conclusion, I'd just like to take this opportunity to congratulate all the participants, their communities, the community advisory boards, the investigators and the site staff, particularly at the 7 trial sites in South Africa, on this tremendously exciting result. This is a great success, and it is shared success for all of us, and one we hope that will lead to the expansion of HIV prevention options for women globally, and ultimately to reductions or elimination of HIV acquisition. We recognize that we're here because of the tremendous collaboration of many stakeholders, and I'd like to appreciate the support of FHI 360, the Statistics and Data Management Center, the Laboratory Center, the HPTN Network, and our in-country partners. We also want to acknowledge the study sponsor, the Division of AIDS at the National Institute of Allergy and Infectious Diseases in the US, as well as the funding partnership of the Division of AIDS, the National Institutes for Mental Health, ViiV, and the Bill and Melinda Gates Foundation, as well as the generous contribution of study drug by Gilead. Thank you very much.
Thank you very much, Sinead. I just wondered if Professor Rees wants to add anything to this. I am going to indicate to you that we will be putting out a media release, and would also encourage you to ask questions either in the Q&A or in the chat. Helen, anything from your side that you would like to add?
Well, I think just to reinforce that this is a major breakthrough, as you've heard from Sinead, that there are additional scientific and clinical questions that we still have to answer. So we're not looking at something that's going to be available immediately. But clearly this is going to be fast-tracked both from the clinical research point of view and the manufacturing side, because access to this for a country like ours with such high numbers of infected young women and new infections every year, it could be a game changer. But so I think we're very happy to share the sort of timelines that we think and the other clinical questions, as Sinead mentioned, that need still to be answered. But we'll have to have a little bit of patience for some months. I think COVID has made us think that we could do everything overnight. And in truth, making sure that things work and they work in the populations you want them to work into, we've shown that. But asking some of these other questions and then getting manufacturing up and distribution up will take a little bit longer.
Thank you very much, Helen. If I could just ask, there is already a question in the chat box or in the question and answer section, that if people who are asking questions, I see your name, but if you would also be so kind as to let us know which organization you are from. Now, my great pleasure to introduce Professor Zeblan Vilakazi, the Deputy Vice Chancellor at the University of Witwatersrand, and as indicated previously, the Vice Chancellor designate, taking on this responsibility on the 1st of January. Professor Vilakazi.
Thank you, Professor Vela. Good morning, everybody. Let me first thank the media for making themselves available and helping us convey this message on this remarkable breakthrough. I'd like to congratulate the Wits Reproductive Health and HIV Institute on this very important study, and thank the partners who have made this trial possible. I will list them as following: the National Institute of Allergy and Infectious Disease, NIAID, the National Institute for Mental Health, the Bill and Melinda Gates Foundation, and the VIIV Healthcare. It's very important that as we celebrate again another achievement in a quest to find a solution to some of the two most pressing healthcare challenges of our time, that we reflect as an institution, research-intensive institution like Wits, that we partner with global partners and continue doing the work that has been on show today, where we partner with global partners and are not just the recipients of global knowledge, but our scholars, our leading scholars like Professor Sinead Delany-Moretlo has shown, and Professor Rees have shown, that we can, as South Africans and as Africans, working at African-based institutes, partnering with global partners, are able to collectively find some of the solutions that we need to address both locally and globally. Research-important universities are important in a sense that they allow us not only to push the frontiers of the mind, but also create space whilst pushing the frontiers of the mind, address some of our pressing to the burden of disease. It is therefore to me, a very remarkable day, an achievement, and I'm very proud of the excellent work done by my colleagues in playing a key role in not only just pushing the frontiers of the mind, as I mentioned earlier, but also in making lives of ordinary women and children improve. I think the role of research-intensive universities is to do that, whilst advancing knowledge, at the same time being able to address some of the pressing needs. And therefore, this achievement of today is an example of the combination of both research and its application to improving the welfare of all in our society. And in that regard, we have played a key role in addressing the Sustainable Development Goals of the United Nations. It is very important that we tell more of these stories and change the global narrative around how Africa and the African continent and the research enterprise that emanates from this continent is perceived across the world. So we hope that the media will keep a sharp focus on new developments that will emerge, not only from Wits, but from other research entities in the country. I thank you. Thank you, Prof. Vela.
Thank you very much, Professor Vilakazi. I'm going to suggest now that we start addressing some of the questions that have been asked, and I'm going to be reading those that I have seen in the question and answer and in the chat box, and we'll do them as best as I can in the order that they came in. Question asked by Ms. Lopez Gonzalez of the Mail and Guardian. 3 parts to it, and if I could ask Sinead and Helen to take on these. 1, how much does injectable cabotegravir cost, and how does this compare to the cost of Truvada? Secondly, how do you believe that countries will be able to leverage the existing ways many countries use birth control injections to roll this out? And thirdly, what, if any, data do we have for this in pregnant women, and how will this gap be filled? Sinead?
Yeah, thanks very much for those important questions. So I think in answer to the question of cost, and I've seen a lot of that in the chat as well, the company that makes cabotegravir, ViiV Healthcare, have not allocated a cost yet, but what they have articulated in multiple fora is their commitment to access, particularly to low and middle income countries in the region where HIV is most prevalent. And they obviously have been committed to dolutegravir access, so we look forward to kind of hearing more about that story. In terms of your second question about leveraging family planning services, obviously this has been a big discussion about HIV prevention and the need to integrate HIV prevention into other sexual and reproductive health services. I think the results that we saw are very impressive, and I think reflect the enormous desire that women have for a range of prevention options that will fit into their daily life. And obviously we know how acceptable the injections for contraception are. So I think there will be a lot of work done to look at how to integrate injections into family planning services once these products are licensed. And then your last question about pregnancy is also an important one. We acknowledge that this is a group that's often left behind, and women are at risk for HIV during pregnancy. During the cabotegravir trial, you will recall there were some concerns about dolutegravir, and we had very strict criteria about preventing pregnancy in the trial. Nevertheless, we did see a number of pregnancies, and we imagine that in the open label extension, there will be possibilities, now that the concerns about dolutegravir have receded, to study the question of the safety and efficacy of this product in pregnant women going forward.
Great, thank you very much. Susan Cilliers of Netwerk 24 and Build also asked the issue regarding to cost. And once it will be available, I think in part you've answered that. Would you just like to reiterate that?
Yeah, well, just I think to reiterate that access is an important commitment that has been made by ViiV Healthcare. They haven't assigned a cost yet, but obviously this is going to be an important question as we move forward. And as Helen mentioned, there will be a period during which there will be submissions for licensure. So this is probably something that will become available in the next 2 or more years. And in the meantime, it will be important to understand what those costs are.
Great. Two questions from Graham Rabenheimer. One is, will we be releasing this recording of this interview? I'm sure we will be, Graham, but I would like you to be in contact with the media people at the university to confirm that. Second question that you asked is, how much longer the study will continue for? How much will the study cost? What's the response been from international entities?
Yeah, thanks for that question. So I think there's been overwhelming enthusiasm for the results. I think this is a really important result and advance for women. As you know, particularly in this region, more than half of women are infected with HIV. New infections are in HIV, and women bear a disproportionate burden of HIV in our region. Although we've had access to oral PrEP, I think the finding that injectable PrEP is so much better than oral PrEP really means that we have an additional option that will fit into women's lives and hopefully help us roll back the tide of HIV. So the response, as you can imagine, has been very enthusiastic because of what it means for the field generally and for women in particular. As to how long the study will go on, the blinded portion of the study will be stopped because we've answered the primary objective. And what we will now do is follow up participants on study. Initially, they'll be informed about their study arm allocation. And when we're able to access cabotegravir supplies and complete all the regulatory reviews, we will offer them the chance to remain and follow up. That will certainly be at least 48 weeks, so a year, possibly 2 years. These are negotiations that are ongoing. And I think it's really important to emphasize how important post-trial access is to us. So that will be an ongoing conversation also with the drug manufacturer.
Thank you. The next question then comes from Amy from Spotlight, who asks, are the results, one, because oral PrEP is just not that effective, or two, because adherence to oral PrEP in the study was poor? And then could you also please give percentage of adherence for both arms, if you're able to estimate this from the drug level data?
So thanks, Amy. That's an incredibly important question, and I think it's important that everyone understands this. In fact, both products were highly effective. We saw an incidence rate in this trial of 1%, and I think you'll recall earlier results from vaccine trials presented this year, which showed an incidence in the absence of prevention interventions of about 4%. So we made significant inroads into reducing infection in women, and both of these products were highly effective. What we hypothesized, and I think what we have shown, is that injectable PrEP would have an adherence advantage over taking a daily pill a day. And there are many barriers for women to take a daily pill a day. And so this is why we have seen the superiority that we have seen. I mentioned that in a subset of samples that were collected, what we assessed was that 68% of those samples had detectable concentrations of tenofovir. This is a lot higher than what we've seen in other studies and suggests for us that women were highly adherent to both interventions. And so this is an important result because it highlights that both interventions are incredibly effective in preventing HIV in women.
Next question from Edwin Naidu, who's from the Sunday Independent and University World News. Congratulations on the breakthrough. Given the need for a vaccine for COVID-19, is there diminishing interest in addressing HIV/AIDS given the current pandemic? Secondly, what impact on HIV/AIDS is envisaged by researchers from the solution on these stats? For example, 250,000 women in South Africa annually. How much of a game changer will it be for ordinary men and women and children? Maybe, Helen, if you would like to come in with the COVID question and then Sinead with the other component.
It's a very good question. And I mean, clearly, novelty, fear, and the pandemic obviously displace lots of our thinking and our focus for very good reason. But I do think that what the pandemic has shown us is that there are other pandemics going on, if you like, but the HIV epidemic has raged around the world for many, many years now. And in partner with that, so has TB. And I think you're probably, as a health journalist, you're very aware of the fact that one of the the outcomes of COVID, the impacts rather of COVID, has been that we've seen a diminishing uptake of our HIV and TB drugs, and for TB a diminishing in testing. So we've had a secondary knock-on HIV and TB, as with many other preventive and curative services. So, but that's really been highlighted. I'm hoping that, and I think we will, I think we all appreciate that with time we will get on top of COVID-19, particularly if we do get a vaccine. But I'm hoping that what this actually does is highlight the incredible importance of not neglecting these diseases. Some of the early vaccines that were developed for COVID-19 were developed by a group called SEPI, and I chair their scientific committee. And in January of this year, we looked at this emerging virus. That organization was set up after Ebola because there was a real recognition in the world that we are neglecting certain diseases. And in that organization, we are neglecting diseases that have pandemic or outbreak potential, and diseases that particularly affect low middle income countries, including the African region. So there is a growing understanding that we can't neglect diseases. And for HIV/AIDS, this complacency, and in a way it's a good complacency because it is that because we developed effective treatment and we're rolling it out. But I think that this hopefully will remind us that the best thing to do with viruses like this is to prevent them. To continuously try to respond, as we're trying to do with COVID, is going to be a thankless task that will continue to undermine the health of communities, and particularly in the countries like ours, which are most affected.
Great, thank you very much, Helen. So, Sinead, would you just talk on the issue in terms of what this solution will have an impact on the HIV/AIDS, and then also this issue in terms of whether this will be a game changer for ordinary men and women?
Yeah, so I think many people are talking about this as a game changer, and I think it's because this is the first time that we've seen such a significant HIV prevention result for women. As to sort of how to quantify that impact, that's one of the important questions this study will address through mathematical modeling, so we can understand a little bit better what size of that impact may be. But I think we're all very excited because we have an additional prevention option that's highly acceptable for women, that they're able to use, and that was able to prevent as many infections as we saw in this trial.
Thank you very much. Next question then is from Ina Skosana from Conversation Africa. Have these findings been published?
Our intention is to publish them. Just to remind everyone that these results are being presented partly because at an interim review of our Data and Safety Board, they saw such a significant effect that they felt it was important to share these results. Obviously, this is before sort of the planned ending of the study, but what we hope is to present these results at international conferences and in a peer-reviewed manuscript in the coming months once we've completed all these analyses.
Great. Two further questions from Amy Green. In previous studies, oral PrEP has generally appeared to be close to 100% effective when taken correctly. In that light, an 89% improvement seems odd. Please explain. Then the second question, could you please give me the following numbers? Number of people as a percentage of people on the injection became HIV positive, while the number of people as a percentage of people on oral PrEP who became HIV positive.
Yeah, so I think, Amy, what you raise is a really important point, which is that we believe that antiretrovirals are very effective in preventing HIV infection. The challenge with Truvada is that it relies on consistent daily pill taking. And we've seen that particularly with women, there's not a lot of forgiveness, that if people miss a pill a day, it can reduce drug levels and it can make them more susceptible to HIV infection. And in fact, this is what we saw in the early placebo-controlled trials, where women were not able to take a pill a day, and therefore we didn't see prevention in women. So the reason that this result is so exciting is, number one, that we've seen such low levels of HIV infection in both populations, suggesting that both products work, but that cabotegravir is far superior to Truvada in preventing infection. And we think that's because of the adherence advantage that it confers, that taking an injection 8 weekly is far easier for many women than taking a pill a day, and overcome some of the challenges that they've experienced, which are both related to just the habit of taking a pill a day and remembering to take a pill a day, but also the social pressures that come with having bottles of pills around, and people assuming that they're sexually active, assuming that they may be HIV positive. Injections are discreet, they fit into women's lives, and so this is why we think we've seen such an impressive effect of cabotegravir. In terms of your second question, just to kind of reiterate, we saw in total 38 infections, and in the cabotegravir arm, we saw 4 infections, and in the Truvada arm, we saw 34 infections.
And those as percentages, I remember the one in the injectable arm was 0.21%, and presumably the other one was then about 1.8%.
That's correct.
And that was the question that Elsa B. Britt, who's a freelance journalist for Ground Up, also asked. At this stage, I think we've asked all the questions that were in the question and answer and in the chat. Sharona, is there an opportunity for people in the audience to ask questions? It's not something that I can see through this particular site.
Yes, thank you, Prof. And my colleague Deborah will just alert us. But if anybody wants to ask questions, we're happy to take them live now. Okay. If I could just add that I've just posted the link to the press pack in the chat if anyone needs that, and it is publishing on both the websites now. So the press pack will be available immediately after this press conference. It is available via the link in the chat.
Just a question that was asked by Mr. Rabenheimer, will the videos be made available as well?
Yes, so as soon as the session closes, we will get a recording and we will circulate that together with the press pack to everyone who's registered for the session.
Great, okay. Thank you.
I can't see any other live hands now. Deborah or any of the other hosts, can you see from your side? If anyone wants to ask a question, they just need to raise their hand.
I don't see any hands from our side.
Great, thank you very much. Under those circumstances, we'd firstly like to thank everybody from the press who attended. We think that this is incredibly exciting information. And as has been pointed out by both Professor Rees and by Dr. Delaney Moretwa, really significant findings that undoubtedly will have a dramatic effect on the well-being of people and hopefully will also have a significant effect in terms of what happens around the HIV pandemic in this country. Sorry, there is a further question that just come in from Rhoda Odihambo. Some studies showed that for PrEP to be effective amongst women, they need to take it at least for 7 days or to build a wall of protection against HIV. For how long taking CAB will be protection against HIV, be immediate or after a while?
So that's a great question, and what we are currently doing is conducting analyses of samples to look at drug concentrations so that we can provide an answer to that question in more detail. So those data will be to follow.
Right. If we don't have any further questions, greatly appreciate again everybody attending, and also thank you very much to our panelists, and particularly to the researchers at the Wits Reproductive Health Institute. And thank you again. Goodbye.
Thank you.
Thanks. Goodbye.
Thank you, everybody. Goodbye.
Thanks all.
Thank you.
All right, there you go. A major announcement there. So in a nutshell, just in case you were confused by some of the terms you heard, a HIV drug study has shown a long-acting injection is more effective than current daily HIV pills to prevent HIV in women. Now, the trial, known as the HPTN-084 trial, was headed by Dr. Sinead Delaney-Moretlwe. And in a statement, she says that the results from this trial are incredibly important for women in Africa, where lowering HIV incidence remains a priority. And she went on by saying that we know that adherence to a daily pill continues to be challenging, and an effective injectable product such as the long-acting CAB, they call it CAB, C-A-B, is very, very important additional HIV prevention option for them. We heard from Professor Helen Rees as well, and she was saying that there's still some additional scientific as well as clinical questions that still needs to be answered. So you won't have this product ready immediately, but still a major breakthrough. With regards to the cost hasn't been articulated as yet from what we heard, but it seems that access will be a priority to this. So manufacturing and distribution will take a little bit of time, but still a major announcement with regards to this. We'll try to break it down in our later bulletins, but still major announcements with regards to using this injection every 8 weeks or so. Yeah, every 8 weeks rather than a daily pill. Big news there.